Hey everyone, it's Sarah with RegisteredNurseRN.com, and in this video I'm going to be going over lung auscultation, specifically the sites of where you auscultate. And I'm going to be going over normal breath sounds versus abnormal breath sounds. And as always, you can access the quiz and the notes over here or in the description below. Now in the next video, I'm going to be performing an assessment on a patient and show you how to listen with your stethoscope to these sites. So let's get started. First, let's talk about our objectives of this lecture. What I want you to learn is lung anatomy, because it's really important you know what you're listening to. The specific auscultation sites, I'm going to give you some landmarks to make your job easier so you'll know what intercostal space correlates with which lobe of the lung. We're going to go over some audio clips of normal breath sounds and where you should hear them at, because that's a big thing. You should know where you should hear bronchial versus vesicular. And we're going to go over abnormal breath sounds, and I'm going to let you listen to them and you can compare the two. So first, let's go over lung anatomy. Whenever you're auscultating, you're going to be listening to the anterior part of the chest and the posterior part of the chest. Now, one thing you want to remember, whenever you're listening to anterior, mostly what you're going to be hearing a lot of, because it's predominantly in the anterior part, are the upper lobes. However, on the posterior part, what is predominantly made up on this is the lower lobes. So first, let's take a look at the anatomy of the anterior part of the chest. In this illustration, you have your right lung and your left lung. And how I set up this illustration is that I wanted you to be able to see what is over the lungs, because whenever you're listening with your stethoscope, you need to know where your clavicle is and certain intercostal spaces, because they correlate to which lobe of the lung you're listening to. For instance, if you're listening down in the sixth intercostal space, mid-axillary, you're assessing the lower lobes of the right and left lung, which we'll go over in depth whenever I cover these auscultation sites. So first, let's cover the right lung. Your right lung is made up of three lobes, very important. So you have your right upper lobe, then you have your right middle lobe. And right here you have the horizontal fissure, and then you have the oblique fissure. And this just separates the middle lobe from your upper and your lower. And then down here you have your right lower. Then over here you have your left lung. You have your left upper lobe and then your left lower lobe. And if you notice in the drawing, mainly whenever you're listening to your lungs, you're mainly going to be assessing, because you can see more of it, of your upper lobe. Then we have our trachea, which is up here, and it goes down and it branches off into your bronchus, your bronchi. And then your bronchi go even further and branch off into bronchioles with your alveolar sacs. And this is where gas exchange occurs. And then of course you have your breastbone and all your ribs right here. Now let's look at the posterior view of the lung. Here is the posterior view of a patient's back. If you were to look inside, look at the lungs, you'll have the clavicle on the front, then it comes around and it forms into your scapula, and you have your left lung and your right lung. They're flipped then compared to the anterior view. And here, as you can see, you have mostly lower lobe that you're assessing, and it's separated by your fissures here. So you have your right upper lobe and you have your right lower lobe. Notice you can't really assess the middle lobe like as you can with the anterior view. And then over here you have your left upper lobe and your left lower lobe. And you have your spine in the middle, and it's really important you find C7 to T10 whenever you're assessing, which we'll go over in the auscultation sites, because this will help you know where to place your stethoscope in between the spine and the scapula on those intercostal spaces right in between the ribs. Before you start listening to a patient's lungs, let's talk about some tips to make your job easier so you can get the best sound possible and be able to assess those lungs correctly. Okay, first tip. Listen directly on the patient's chest with the diaphragm of your stethoscope. That is the big part of the stethoscope, which you'll see a little bit later. And the reason you want to listen directly on the skin and not over close is because a lot of times your diaphragm can rub up against the patient's clothes, and that can make like a rustling sound like one of those adventitious lung sounds, and it'll muffle and decrease the sound quality of what you're trying to hear. Also, whenever you are listening on women, you want to have the woman raise up her breast so you can get underneath those sites so you can hear those lung sounds, because the tissue will muffle the noise and you won't be able to hear that. So remember that whenever you're listening on a female patient. Also, whenever you're listening to the chest, you're going to listen to both the front and the back sides. And whenever you're listening, you're going to note a full cycle of inspiration and expiration. And what you're listening for is you're listening to the pitch. Is it high? Is it a medium or low pitch? What's the sound quality? And its duration. Is inspiration longer than expiration, or vice versa, or are they equal? Which are characteristics of normal breath sounds. And on that sound that you're hearing, is there any extra adventitious sounds that shouldn't be there, maybe on inspiration or expiration? So you really want to note that. And whenever you listen, you are going to start from the top and work your way down. And you're going to compare sides. So be something like this. You're going to start up here at the apex of the lung, listen here, and then you're going to go over and listen on the other side to compare it. Then you're just going to drop down a little bit, listen here, and then you're going to go over here and compare sides. Drop down again and just keep repeating until you've reached the bottom. Another thing what you want to do to help get the best sound quality is have the patient sitting up so you can get to the front and the back of that chest. Posteriorly, because this is an area that may give you trouble, because as we went through the anatomy, you have your spine here and you have the scapula here. So if you have the patient sort of move their arms forward, maybe in their lap, to separate those shoulder blades, you can get in those little intercostal spaces better so you can put your diaphragm and listen to those sounds. Also, whenever you're having the patient breathe, you want them to breathe in and out through their mouth slowly so you can hear those lungs inflate and deflate. However, a lot of patients who may have breathing difficulties, you'll have to take your time with them because they can hyperventilate easily, and make sure your patient doesn't get dizzy, and just take your time while you're having them breathe. Now let's go over the auscultation sites. Okay, first we're going to assess the anterior part of the chest first. And what I like to do is I find the clavicle, and we're going to start at the apex of the lungs, the top of the lungs, and we're going to get our diaphragm, which is the big part of your stethoscope, and you are going to place it right slightly above that clavicle where the apex is. You're going to listen there for a full inspiration and expiration, and then you're going to go over and compare on the other side. And this is listening to the apex of the lungs. Then you're going to find your second intercostal space. This is one of those landmarks we were talking about, because this is going to assess our upper lobes of our right and left lung. And this is found mid-clavicularly, so the middle of where the clavicle is, in the second intercostal space. So you will listen here, compare your side, and then just go a little bit lower, maybe into the third intercostal space, and just keep listening to those upper lobes. Then we're going to go down to our fourth intercostal space. This is another big landmark for specifically the right middle lobe. So we're going to go down to our fourth intercostal space. We're still in the left lobe, in the upper lobe, and now we're going to go over here and compare sides. Now we're in the right middle lobe, and this again is mid-clavicularly, and we're listening in here, and then we'll just inch a little bit down, maybe in the fifth, and still assess our right middle lobe, and then we'll go over and compare sides, still being in the upper lobe on the left side. Now we will inch down to the sixth intercostal space, but mid-axillary. So where their armpit is, go midway, and we're down in the lower lobe of the lungs. And we'll have them inhale and exhale, and then we'll go over and compare it on the other side, which we're in the right lower lobe here and assessing this. And then we'll just inch a little bit down, maybe to the seventh space down the lung, and just listen in those lower lobes a little bit more and compare sides. and then we're done. Now let's look at our sides on posterior. Just like with anterior, in the posterior, we're gonna start from top to bottom and compare sides and work our way down. And we're going to start right above the scapula, right where the apex is. And we're gonna listen here, and then we're gonna go over to the other side and compare. And remember, to get the best sound quality so you can hear, so you're not listening over the shoulder blades, because that will muffle your sound and you won't be able to hear, have your patient put their arms in their lap or just separate those shoulder blades from each other so you can get in between that spine and shoulder blade area. Then what we're gonna do, we want to assess first your upper lobes. So from C7 to T3, your cervical and thoracic spine, that is where your upper lobes are. And as you can see, here's your fissures right here, and you have the upper lobes there. So what you want to do is just go in between where the shoulder blades and the spine are and just work your way down. So we're going to listen to our upper lobes. So we'll go here, and then we'll compare over here. And then we'll go down a little bit towards where T3 is. Listen here, still being in the upper lobe. Then we'll go over and compare sides. Now, from T3 to T10, that will allow us to assess our lower lobes. So we'll start around T3 and work our way down. Again, just staying in between where the scapula and the spine is. And we will just compare sides and inch our way down. And you want to move around almost mid-axillary where you were moving before on anterior. So you can just get a good feel for what's happening in those lower lobes. First, let's start out talking about normal breath sounds. Okay, there's 3 different types. A tip for whenever you're trying to learn these normal breath sounds is to get a stethoscope, listen to yourself or listen to others, and get a rhythm down for how long inspiration, expiration is, and where these are located, because that's the key with these 3 different sounds, because they're heard in different areas throughout the lung field. So let's go over them. The first one is bronchial. This is heard anteriorly only. You're not going to hear this posteriorly. Anteriorly. Why? Because they are mainly heard over the tracheal area with the stethoscope. So up here in this area. They are high pitched and loud. And you will notice when you listen to them that the inspiration will be slightly shorter than the expiration. And this is what bronchial breath sounds sound like. Next is bronchovesicular. These are heard both anteriorly and posteriorly. And posteriorly, you will hear these at the first and second intercostal space. So about in this area right in here with your stethoscope is where you're going to hear them anteriorly. Now posteriorly, you're going to hear them in between the scapula. So about right here where T3, T4, and the small little areas where you will hear those. And they will have a medium pitch to them, and inspiration and expiration will be equal. And here's what bronchovesicular sounds like. And the third breath sound is called vesicular. This is heard again both anteriorly and posteriorly, and it is heard throughout the peripheral lung field. So you're going to be hearing these all throughout in this area over here anteriorly and posteriorly. And it will have a low pitch that will be sort of soft, and inspiration will be greater than expiration. And here is what vesicular sounds like. Now let's talk about those abnormal breath sounds that you could hear that may be thrown in with those normal breath sounds. Okay, they are separated into continuous and discontinuous. Now first let's go over continuous. What does continuous mean? This is an extra sound that you're hearing that is lasting more than 0.2 seconds with a full respiration. Okay, the first type is called a high-pitched polyphonic wheeze. Let the name help you. Okay, so what is it? It is mainly heard in expiration, so when the patient's breathing out, but it can be in inspiration as well. And it is a high-pitched musical instrument sound with many different sounds to it. That's why it's polyphonic. And this is what a high-pitched polyphonic wheeze sounds like. Another type of wheeze you can have is called a low-pitched monophonic wheeze. And this is again heard mainly in expiration, but you can hear it anytime. But a lot of times you'll hear it whenever the patient's breathing out. It is a low-pitched whistle. So instead of being high-pitched like the high-pitched wheeze, it's going to be low, and it's going to be made up of one sound quality. That's all you're going to be hearing. And it can sound like a whistle or a whine. And this is what a low-pitched monophonic wheeze sounds like. And the third type of continuous adventitious breath sound is called stridor. And this is heard on inspiration because what's happening is that the airway is being obstructed by inflammation or some foreign object, something like that. And once you hear this, you will never forget it. It's very unique sounding. It is a high-pitched whistling or gasp with a very harsh quality to it. And patients, like pediatric patients, if they get the croup or acute epiglottitis, or you have a patient who has an airway obstruction, you will hear this sound. And this is what stridor sounds like. Now let's go over the second type of breath sounds, abnormal breath sounds, called discontinuous. This is an extra sound that you're hearing that is lasting less than 0.2 seconds. Okay, first type is coarse crackles. Crackles formerly has been known as rales. So if you hear that, that's what it means. Crackles, rales, they're interchanged just like rhonchi and wheeze. So coarse crackles, they are mainly heard in inspiration when the patient's breathing in and can extend into expiration. And what it will sound like is a low pitch, wet / bubbling sound. And this is what coarse crackles sounds like. The second type of discontinuous abnormal sound is called fine crackles. This is heard on inspiration, and it is a high-pitched crackling sound. Compared to the coarse crackle, this is like low pitch, like a bubbling noise. This fine crackles is high pitch. It sounds completely different than coarse crackles, and it has like a crackling of a fire sound to it. And the key with this is that it does not clear when you have the patient cough. So you listen, you hear that, you ask the patient to cough, and it's still there. That would be fine crackles. And this is what it sounds like. And the last sound is called a pleura friction rub. This is heard both on inspiration and expiration, and it is a low-pitch, harsh, grating sound. And what's causing this is that your pleura on your lungs, those two layers, are rubbing against each other. And they normally have this little thin layer of serous fluid around the lung, but it doesn't right now due to all that inflammation going on. So you can actually hear that when that patient's breathing in and breathing out. So that's why you're hearing it on inspiration and expiration. Now, it can sound similar to a pericardial friction rub. How do you tell the difference? If you are wanting to know, is this the lungs or is this the heart, just listen, have the patient hold their breath, and if you can still hear that harsh grating sound, it's the heart, because they're holding their breath, their lungs aren't moving, so you've ruled out the lungs. And this is what it sounds like. Okay, that is lung auscultation and normal breath sounds versus abnormal breath sounds. Don't forget to take the free quiz on the website and check out the other videos in this series to help you with lung auscultation. And thank you so much for watching, and please consider subscribing to this YouTube channel.